Good evening, everybody. I welcome you all in this Corona third lockdown. The time has come to talk on the webinar, but at the end of the day, I always feel like meeting people, those who are in faculty and some of you that we have met in person as well. What we are going to discuss today is the bone scalpel and cutting edge technology. We have in our webinar Dr. Sajan Hegde. He's the boss, everyone knows. He's the one who started the artificial intelligence use in India. He's working at the moment Chennai, and he's our past president of ASSI. I welcome Dr. Sajan in this webinar, and he's going to highlight cases and his videos as well. The another eminent faculty is Dr. Ajay Prasad Sethi. He's the surgeon who is from Makkah of spine surgery, that is Ganga Hospital. We have had few occasions of working together, and we know he is one of the excellent surgeon too. We have another faculty, Dr. Bhavuk Garg, who is additional professor, AIIMS Delhi. The man who doesn't probably need introduction to, like the previous two speakers as well, but he is known for his record keeping, and he is one of those excellent deformity surgeon as well. And I have privilege to introduce my own colleague, friend, and the everyday sort of, the person whom I talk every day, maybe once, twice a day, Dr. Ajay Krishnan. He is the one who has probably 3D vision in the deformity work. I have seen him operating from 110 degree to near 20 degree kyphotic deformities. So we have Ajay Krishnan with us. So without wasting time, I hand over first Dr. Sajan. He wanted to speak for a few minutes, and afterwards we will switch over to Dr. Bhavuk Garg. He's going to do the introduction of the bone scalpel, and followed by Dr. Ajay Prasad Sethi, who is going to show us cases and the video presentation, and followed by Sajan, Dr. Hegde. He's going to talk us about few cases as well and how he uses the bone scalpel, and followed by pros and cons of this new technology bone scalpel by Dr. Ajay Krishnan. And at the end, I will conclude with the aerosol and how do we prevent this aerosol generation, or how do we sort of protect ourselves from this aerosol. So over to Sajan. Sajan, I have unmuted you.
Good evening, gentlemen. So it's a pleasure to be here. This is in fact my first webinar. So I have kept the coronavirus away from me, and I have also kept the webinar virus away from me. But when Bharat called me and said, why don't you take part when we are talking about the ultrasonic scalpel, it excited me. It excited me because I feel it is the tool that all of us need to have it, whether we like it or not. And when I first saw it, maybe some 8-9 years ago at some conference in Europe, and this guy was able to remove the top of the eggshell without disturbing the egg yolk, it fascinated me how it could be done. And I think we were the first to get this tool in this part of the world. Initially, we didn't understand its applications, but today, as I will show you, it has replaced most of our standard tools, and it is something that we use every day. Thank you, Bharat, for having me as part of this webinar. Thank you very much.
Well, I must thank you for accepting and coming over on this web webinar. I must thank you. I really am feel, honored that you have, accepted our invite. Now I request Dr. Babuk to take over. I think I have unmuted you. You can start. Babuk, please.
Good evening, Dr. Sajan, Dr. Ajoy, and Dr. Ajay Krishnan.
Good evening. Good evening. Can they hear us? Yeah.
So I will be covering the basics of UBS. We know it's a novel ultrasonic surgical device, and we all know that it cuts bones and spares the soft tissues, which are very important when we talk about the spine surgery, like dura and the neurovascular structures. It also has a relative selectivity for bone destruction, and why is it so? We will discuss as we go along. And recently, this tool has been promoted as ideal for spine surgeries, and why is it so? We will just see. So this is the usual assembly. It has got a generator. It has got a tubing which connects it to the handpiece, and the handpiece bears the terminal working piece. So basically, if we look at the ultrasonic assembly, it's a generator or the irrigation console. It basically amplifies the electrical signal and converts into a high back and forth motion of a blunt blade at the extremely high frequency of around 22,000 times per second. The working tip, it can either be in the form of a blade, which comes in different lengths, usually in around 10 to 20 millimeter in length and 0.5 to 1 millimeter in width. And it works basically as an ultrasonic osteotome. While if you look at the burr and the shaver, they are the non-rotating burr for the bone, and they basically ablate the bone whenever they come in touch with the bone. So this is like the usual amplitude. You can see that the blade, it comes forth and there is an amplitude, and this blade goes forth and back in this amplitude. And I will show just a video that how does it move. So basically, this is this movement which creates the final transfer of energy to the bone. If we compare the ultrasonic bone scalpel to the traditional methods like the high-speed burrs, the problem with high-speed burrs is that there is a considerable vibration and torque, and which creates a Weed-Waker phenomena. We will just see what is Weed-Waker phenomena. And if we look at the osteotomes, so osteotomes, it also provides energy transfer from the osteotome to the bone, but there is a risk of plunging into the neurovascular structures. And problem with carisons are the fatigue, the manual fatigue, which we surgeons all know that if we have to remove a lot of bone, then it can lead to the fatigue failure of your hand as well. So this is the normal burr. We know it can create so much rotatory force, and it can entangle the neurovascular structures. While if you look at the ultrasonic scalpel, so it takes out the bone as en bloc because of this 2 and 4th motion. It exactly works like an osteotome, but here the energy transfer is much more stable and in much more small amount of transfer. While the burrs, they ablate the bone whenever they come in contact. So this is like the Weed-Waker phenomena. You can see that when you move the burr, then it can also take out the surrounding the structures into this destruction. So there is always a risk of getting the important neurovascular structures get entangled into the burr. While this is just a small video that how does it work, this ultrasonic bone scalpel. So there is usually 50 to 60 hertz of electrical activity which is transferred to the ultrasonic generator. Then this ultrasonic generator transfers it through the piezoelectric mechanism, transfers to the 2 and 4th motion, which is approximately in the range of 22,500 oscillations per minute. And then there is a fluid channel inside it, and this fluid channel actually gives makes the tip of the working instrument cool, which is very essential because this high oscillation rate makes it very hot. This tip of this, so one surgeon has to be very careful whenever he's working that he's careful about the extreme thermal energy at the tip. So obvious uses, they are in facetectomies. You can use them for laminotomies, laminectomies, and block resection of the bone. You can use it for the Smith-Peterson osteotomies or the pedicle subtraction osteotomy. So these are various uses, common uses. There are other uses as well. So why does it have so much selectivity for bone? Because it transfers a large amount of energy within a small amount of bone at the point of contact. And the soft tissue structures, because they have the capacity to bend, deform, or move away or vibrate upon contact with the blade, so they dampen the energy transfer. However, it is not absolute. If you keep the tip of the instrument very long in contact, which is usually around 10 seconds, then it can it can damage these structures as well. So one has to be very careful when they are using this ultrasonic bone scalpel. So when we talk about the bone cutting technique, we can see that this is a 3-step process. So in the first step, you just cut the upper cortex, the near cortex. So you just give a small lateral movements with little axial pressure to score the outer cortex of the bone to be cut. While in the second phase, when you enter into the cancellous area, then you give more axial pressures, and then you can liberally you can lateral sweep to cut through the cancellous bone because it is very soft. And then finally, when you reach the inner cortex, then again you make short lateral swipes with controlled cyclical forward and backward movement to penetrate the inner bone cortex. So this is the C step. That the third step is the most crucial, because here you have to develop the tactile feel to feel for the inner cortex breaking away or the giving away. So advantages are that it's a high precision cutting instrument. You can cut the bone in any shape, whatever the shape you want. So your osteotomies, they can be precise. You can measure the perfect angle. There is ample literature now that there's a notable reduction in the osseous bleeding because it coagulates the small venules at the surface of the bone. Obviously, there is a safety towards dura, which we just discussed. And then, as compared to the burr, when there is a lot of bone debris which goes away, you can have a lot of autograft, so you can use it for fusion purposes. So this is just a paper which I've taken, and you can see that the shape of the osteotomies, they are perfect, they are highly precise. And there are ample literature now regarding the blood loss reduction also during the AIS surgeries as well. Now, this is just a small video. You can see here that we are cutting, and you can see, we as a spine surgeon, whosoever is doing osteotomy, he knows that there is so much bleeding at this step when they are going through this osteotomy. But with ultrasonic scalpel, you can see that there is hardly any bleeding when you are doing this pedicle subtraction osteotomy. These are just some of the examples, where we have done so much osteotomies with very much little blood loss when we use this ultrasonic scalpel. Like this was a 3-year-old boy where we had many concerns because the whole blood volume is just less than 1 liter or 1.2 liters in this age group, and we know that this child needs vertebral column resection. And when we did vertebral column resection with using this ultrasonic scalpel, you can see this scalpel in the intraoperative X-rays. So the whole blood loss was less than 400 ml in the whole surgery in this child. So again, the another advantage is that you can use cottonoids, which is not possible with the burr when you are using burrs. There are ample literature that it takes less operative time. There is a learning curve is quite short. As per the literature, you just need 15 cases to be master of this technique. And we have also seen that whenever we have taken bone graft from the iliac crest using this ultrasonic bone scalpel, so there is a less pain. So the theory is that it also destroys the nerves endings at the edges of the bone at the periosteum. So again, there is less pain. So we have witnessed in our many cases. So we take bone graft using this ultrasonic scalpel. One has to avoid plunging to the dura because if there is an unduly force on the dura, it can damage the dura as such. One should avoid lingering over the dura less than more than 10 seconds. And one has to be very careful when you're using this device when the dura is likely to be adherent. There are techniques, I'm sure we can discuss them. When the dura is adherent, then you have to use this device very carefully. So the tips are, you have to develop a tactile feel, so you can practice on a bone model beforehand. You can palpate with scalpel off, so when you are reaching the inner cortex, you can always feel that you have, with the scalpel off, whether you have breached the inner cortex or not. Always plan your cuts to be made before, and divide the work into smaller parts. Also, one of the advantages is that you can take a large piece of bone with this, but it is always better to divide your work into smaller parts. So again, there are less chances of injury. You need some time for developing tactile feel. Again, 12 to 15 cases, they are good enough. You need to pre-plan to cut the bones in advances. Special caution you have to take in revision cases because the dura may be adherent to the bone. Overheating, so again, you have to continue to move the device and not let it bind in one position. And high cost is certainly one of the major downside which people talk about. But if you look at the longer term, then it is much more cost effective. Thank you.
Thank you, Bhavuk.
Do we have? We will take the questions at the end, or we can take right now.
We will have the question in the chat. We'll have the question in the chat. So at that time, we can have that. Is that okay?
Bharat, can I share my screen now?
Ajoy?
Yeah, can I share my screen?
Shetty, you are live, so you can start your talk, please. And
Yeah.
if there are any questions, if you can put it in the chat box, we will cover them at the end.
I'm going to, Bharat,
Please
I'll
put your
start
questions in the chat box.
Okay.
Thank you.
to show a few cases of where we have used ultrasonic bone scalpel. I mean, but unfortunately, I don't have intraoperative pictures. This is a patient with a adolescent idiopathic scoliosis. As you can see, the main thoracic curve is about 107 degrees. And we applied a halo traction to this particular child over a period of 4 to 6 weeks and around 6 weeks. And you can see the deformity has corrected to about 83 degrees. And on the lateral view, she is hypokyphotic. And therefore, this is a situation. The major concern in scoliosis surgery, especially when the rigidity of the curve is significantly more, and when a curve reaches about 100 degrees, is the blood loss. And especially most of these children with the age group of 12 to 13 years are so, their body weight itself is low and the blood volume itself is less. I mean, basically, we depend upon the anesthetic technique. We use tranexamic acid to reduce the blood loss. But in spite of all strategies, the blood loss is significantly high. As Bhavuk mentioned, one of the important contributors to the blood loss is the osteotomy and the decortication site and the venous blood loss. Therefore, in a situation like this is similar to the article. I took it from the article which Bhavuk showed. Basically, as you can see, by using the ultrasonic bone cutter, you can do a facetectomy quite safely without any major issues. The blood loss becomes significantly lesser. This is again from that article where they have done a V osteotomy. I do a slightly varied modification of that, but it helps you to do a Ponti osteotomy much more liberally, number one. And number two, the amount of blood loss, especially when you do in a scoliosis on the convex side, the blood loss is significantly higher. Therefore, the amount of blood loss that tends to happen becomes significantly less. And fortunately for this girl, at the end of the procedure, when we are able to achieve a good degree of correction, both in the coronal and the sagittal plane, the blood loss was only about 500 ml with all the magnitude of surgery what she underwent. And this is similar to the experience. If you see the literature, it is one of the articles in the retrospective cohort, which they are mentioning published in 2019, where there are 84 scoliosis patients, and they compared the UBS versus the traditional instruments like osteotome and Kerrison Ronger for Ponti osteotomy and facetectomy. And they noticed there is a significant reduction in the normalized blood loss, that is for the patient's weight and body weight, and more so in the neuromuscular group as against the AAS group. As we are all aware, in the neuromuscular group, the blood loss is significantly higher. Similarly, one more article which was published way back, and they had initially looked at, and they said the blood loss is less, it's about 30 to 40%. Therefore, this highlights the usage of an ultrasonic burr or ultrasonic cutting device in this use during the various spinal procedures. I mean, we use it for everything, starting from a cervical corpectomy to a cervical laminectomy to a deformity correction, as Bhavuk showed, even for a osteotomy and even for a decompression scenario when you're doing a TLIF, it's easy to remove the facets using a Masonic bone cutter. I'll show you one more example of a 65-year-old lady who presented to us with a cervical myelopathy and significant neurological dysfunction. As you can see, there is an extensive OPLL, which is extending from C5 to T1. And unfortunately, she also had a OLF, which was extending mainly at T3-4 level. Therefore, she did an osteotomy, which was, and as you can see, even at the C3 level, there is an ossification that is bound to happen. Therefore, we plan to extend our laminectomy from C3 down towards T5-6 level. But as you can understand, it's a surgery of greater magnitude. You cross over the cervicothoracic junction. It needs an instrumentation, and any osteotomy can add to an excess of blood loss. This is taken from the Masonic literature, And this is what you do. You basically use a cutting one and you can cut through and through. And as you can see, we are able to do an instrumentation for T3 to C3 to T5 with a very minimal amount of blood loss, which led to an eventual good outcome. And this is published by Bharat, where they did an analysis of 311 patients, and they observed that the blood loss was significantly lesser. There's a minimal injury to the soft tissue, excellent device control, excellent visibility, enhanced accuracy, and it's a versatile tool. I mean, the amount of bone destruction is significantly lesser, and you can do it with more precise nature. As Bhavuk mentioned, these are the three techniques that is used. First, you start with the lateral movement for the outer cortex. You go with the axial pressure, and the liberal go it through and through, like anteroposterior movement through the cancellous mid portion. And then you do the final cut with a controlled cyclical motion. What we do in majority of the scenario is that sometimes I use a burr to thin the outer cortex and the part of the cancellous bone. And then I use the osteotome to do the Masonic cutter to do the final cut. Or the other option is you can use the cutter up to the inner cortex. And there you can use a thin osteotome. Once you have weakened the inner cortex, rather than going through and through, you can put an osteotome inside that gap, and gently by rotating, it tends to break. That's a way to prevent a dural tear, especially in situations when it is significantly adherent. I will just show the video. This is a video done by Bharat when he came to our hospital, and I'll show the way he has done this particular procedure. Basically, he has done the discectomy above and below. This is a corpectomy video. As you can see now, is going with a forward movement. See, the amount of the irrigation is necessary to prevent the heat, and you need to have a blade of a much longer length so that you can perform corpectomy much safer. You get a feel of sensation as you are reaching the anterior cortex, as you are cut through the cancellous bone. That is the anterior rather than the posterior cortex in this particular scenario.
I need a.
No, I'm going, I just showing, this is what I meant. You can use an osteotome to complete the break, and you can appreciate the movement that is happening. For doing this procedure, especially quite comfortably, you have to be sure.
It's come out completely. Wow. You can see that. Yes, with the PLL.
Okay, this is, you can hear Bharat's voice also. I'm not taking credit for it. I told Bharat I'm going to send him the video. This is another way of doing, especially in OLF, which I do it. I tend to use the burr initially to thin the cortex. As you can see, I am doing overall thinning on either side. And then I use the osteotome to do the final part of the cutting. I gently cut it so that when you are doing, the chances that you can separate the dura when it is adherent to the OLF is significantly better. You can see if you are not irrigated, you get a huge amount of heat that is generated. And if you try to dip it inside, if you by accidentally dipping inside, it can cause a dural tear, especially in a patient who has got an adhesion between the dura and the part of the bone. I first started using with the burr, but now I use most of the time the cutter. See, there is a difference between this and the sonopate or the other type of things, which they use for intradural work. That basically works by what is called as the cavitation mechanism. And this basically what we use tend to work by the use of fragmentation techniques. Thank you, Bharat, and that's all it's about from my side. Bharat, you can hear me?
Yeah, sure, I can.
And basically, I use your video to show how you do it. You go through and through, and Ajay go through and through. I tend to use the burr for the outer cortex and the part of the medulla, and then I tend to use the mesonics in the later part to make the final cut, especially when I am using it for a ossified ligamentum flavum, and even when I am using it for a cervical laminectomy. But when I am using it to do a facetectomy, I use it through and through. It's much more controlled, but always tend to complete my final cut with an osteotome put inside and gently rotating it so that the chance of dural tear becomes significantly lesser.
Sure. Thank you. I think let us see from the Dr. Sarjan's end what he does and how he does it. And Sarjan, you can take your time. I'll just unmute you. Yeah, you're live now, Sarjan.
They were the presentations from Bhavok and Ajoy were absolutely excellent, and they addressed quite a few things that we can do with the ultrasonic scalpel. I just wanted to add to Bhavok's presentation is that when you start using the ultrasonic scalpel, you have to be very, very patient. And there is no place for aggressive movements. And you use the tool like a paintbrush. And when you use it like a paintbrush, it's an extremely versatile tool. And it is, as Bhavok said, you have to develop a tactile sense. And when there is a giveaway, when you have gone through the bone, it's very important how you develop this sense, this feel with the tool. So now it's almost similar to the case that Joy showed. So we will just quickly show you a few things. So Ajoy knows very well that he is, of course, many years younger, but we all grew up with these tools, which are our favorite tools. Almost 80 to 90% of our work was done with the tools that you see on the side, the Kerrisons, Rongers, and the osteotomes. In fact, I have to show a carpal tunnel on both sides because of excessive use of Rongers and, of course, putting the screws manually. This is all changing for the younger spine surgeons. But today, we do not use these at all. Almost in my practice, it has come down by almost 60 to 70%. And correspondingly, the use of the tool has gone up. The ultrasonic scalpel has gone up. So as they showed, as the previous speakers showed, you can use it for a variety of conditions, like this patient who had classical cervical myelopathy and uric grade 5. And you can see here, he has multi-level compression. Now, when they have a normal good lordosis, we prefer to do laminectomy from the back and sometimes stabilize them as well. In the past, this used to take a long time. Today, with the ultrasonic scalpel, it takes hardly about 15 minutes for the entire decompression to be done. And it is extremely safe. One thing I would like to point out is that you should never stop. As Bhavok said, you cannot put pressure for more than 10 seconds. And once there is a giveaway, you have to immediately bring it behind, because the thermal energy that is created can create a tear in the dura. So here you see typically how we would do a laminectomy We just got this model yesterday just to show how we do this, and it is as quick as it is seen here. So you mark it out, and then you run across and gently go as it gives way. And once you have done this, you gently lift the lamina and tease it out, remove the adhesions between it and the dura, and that's all. So that's how quickly you can do it. And and then you can, you do your decompression and fix it. Ajoy showed this case. We had a similar case, but this is where I want to show you the extensive use of the ultrasonic scalpel. So like they do in Ganga, we also prefer to put our patients on traction. One thing I hate doing is a VCR for these patients. I do not like to do a VCR to correct these deformities. I'd rather do it in the safest way possible. I do not like bleeding of more than 300 or 400 ml. And that's what we do. We put them on traction and we correct them over 6 to 8 weeks, sometimes 4 to 6 weeks, definitely. So here you see the patient has a very severe deformity, 118 degrees, and we start the traction, and here you can see serially how she corrects over the weeks. Again, in these extreme severe cases, I prefer not to put my screws in the most concave part of the deformity. I prefer to use bands, which is again safer. So here you see we are using the robot to fit the screws. So it is use of the latest technologies to do this type of surgery. We do a peroperative screen. As you know that we prefer to do it on traction. So we correct them further and then do here the Zeem is taking the views. And once that is done, we feed them into the robot, and it becomes quicker, it becomes safer, and you get your screws in a much more precise manner than how you would have done otherwise. And once it is done, the robot is used and the screws are fixed at the levels that you want to. And once you have done that, you then do your osteotomies in the most severe part of the deformity. This is huge, the way it prevents blood loss when you're doing this. When you're using the medicine, there is always the possibility of pressure, and you can do this quickly at multiple levels, and you can go on. And then we also, in this particular child, she had a very sharp gibbous. So we use the ultrasonic scalpel to do the rib resection. Again, it is much safer. There is much less blood loss, and you are able to do it in a much cleaner manner, and you get the bone for the graft. So So that's how you do the resection and the instrumentation. You can see the two bands in place. This deformity of 118 was reduced to maybe around 20 degrees. And that's how she looks after surgery. So it's all about safety and reducing blood loss and doing it in a more precise manner. And I think for today's surgeon, the ultrasonic scalpel, he cannot do without it. I don't think any spine work can be done without having this. So I'm going to show again in revision lumbar spine surgery. This again is a 60-year-old, came with severe radiculopathy. There are a lot of people now doing endoscopic discectomies and all that. I'm sure we will see a lot of them come back for surgery. And this is not to say that endoscopic doesn't work, but perhaps in a number of cases, it's not going to give the desired relief. So this patient, as you can see, has a very gentle listhesis of L4 over L5. You can see the severe compression at L4-5. And the osteotomy, and we always do the CT myelo, which again shows the compression and the reason for his radicular pain. You can see it here. And this is the osteotomy that I prefer to do. I often don't expose on the other side. I expose only on one side. And these are the typical osteotomies that we perform. So one is to remove the facet. That is osteotomy number 1. And once you have done that and the facet comes loose, again, as you know, when you do this, you have a lot of bone that you can use for graft. And then this is osteotomy number 2. We do not remove ever the midline. We make the osteotomy I'm sorry. This is osteotomy number 2. As you can see, it's at the base of the spinous process and the lamina. And once we have removed that, then we are able to do whatever we want to do, the interbody fusion and everything. And have our screws in place. These are put using the robot and the cage. There will come a time when the ultrasonic scalpel will fit onto the robot, and that will be the future. We will be able to do osteotomies, perhaps even indirectly, not even visualizing it directly. So that's how we will do it. A great tool for ossified ligamentum flavum, especially in the thoracic spine, when you have multiple compression. This patient came with paraparesis, spastic paraparesis. And when you want to remove these, this is perhaps one of the most difficult surgeries one can do. The burrs that are available with the ultrasonic scalpel are wonderful tools to remove this pressure and minimize the dural tears. Some amount of dural opening will always happen when you do these type of surgeries. That's it. So essentially, those are the few things that I wanted to show. This is a very versatile tool. It needs one to be patient to learn. One has to use it like a paintbrush. It's a tactile feel that one has to develop. Its applications are amazing. And I think it will be something that all of us will have to have in our armamentarium. Thank you.
Thank you, Sergeant. Great talk. And I think you have demonstrated very well on the bone models. Now we move on to Dr. Ajay Krishnan's talk. And he's going to talk on the pros and cons. If you can just stop the slide share, please. Yeah. Now to Dr. Ajay Krishnan.
Practical things are what you want to take up from any presentation, any talk. Pros and cons. I've removed few slides. Like these are the routine slides which have already been talked, and many of the literature has been covered by Bauk and Shetty also. So clearly it says that the heat production is less and doesn't cause mechanical injury. So that is basically what it causes. And the lowest risk of dural injury is also being reported. These numbers are less, 52 cases in this series. They reported only one case of a dural injury. So, and indirectly you are gaining on the blood loss also. In nutshell, I removed all the presentations, which were all the literature which was on the time gain or shortening the duration. But it really matters when you reduce the time, and you can think why. You have come across many of your teachers. Actually, when you are in the institute, you have seen your teachers, you have seen many surgeons working together, and then you have seen that a person who is gifted to a surgery, do a surgery more meticulously and has spent hours doing that meticulous may end up achieving a poorer result. So that is the cases wherein the result does get influenced by the duration of surgeries, and extensive surgeries, elderly surgeries, pediatric surgeries. This makes immense difference. So we should know where speed matters. For an example, to just cover up, this is one of the patients we did long back, and it was the first surgery done for a hello.
Ajay, your slideshow is not coming.
Okay, I'll go back. Something is wrong. I'll start again.
Yeah.
Sorry. So I'll skip through the slides. I'll just cut through the literatures which is there, and I removed many slides. So basically it reduces the dural tears significantly, the blood loss significantly, already talked about. The safety increases, the time gain, that is what I was talking about. The gained time is very much significant when you are talking about patients who are elderly. You are doing osteotomies, which would reduce your time by say 20, 30, 40%. It would make immense difference to the anesthesia. Pediatric patient, as Bauk told, it is of great importance, significant importance. This is one of the cases which I would just say, a patient who presented with a JO score of 9, and we did a conventional surgery at that time, long back in 2011 or something, and therein it took nearly 115 minutes to complete the surgery. And after the surgery, this was with conventional instruments, and we had a worsened neurology which we took nearly 3 months to recover, again back to nearly JO2, and he was a police inspector. Again, we had this patient 3 years down line with a proximal stenosis, with a further worsening of the neurology, though he was a near normal with a grade score of 1 or 2. And then we again operated this patient, and this patient was operated by a laminectomy en bloc with Mesonic, and this time the time was just 55 minutes. It's not the time which is there. We didn't have a deficit this time, though we could retain that patient in spite of that complication, but we gave a comparative picture. In a redo surgery, you are gaining say nearly 55 minutes for a surgery. It's a complete skin to skin talk time what I am talking. In a 55 minutes time, we finished the surgery off, which took nearly 2 hours for the primary conventional surgery. So it's the hands saved, it's the money saved, it is the energy saved, it is more focused work you are able to do. So these were all numbers which is not which are there. 300. This is large series which again there 307 patients, and again the duration of the surgery, the blood replacement has significantly been reduced. We have an unpublished submitted evaluation. We have just submitted, which was comparative. That's why I'm just quoting it here. It is 55 patients, handheld traditional instrument surgery, and another 45 bone scalpel based surgery for only thoracic spinal stenosis between 2004 and 2014. And in that group, the demography was nearly same, and most of them were the ossifying lesions. The total operative time reduction was nearly 22%, with a per segment reduction by nearly 30%, and the length of hospital stay reduced would be indirect because the number of dural tears, the number of dural deficits are reduced. So it was important, and the blood loss is quite significant, and it was statistically significant as well. And the neurological worsening and the dural tears, they were also on an average reduced as compared to the conventional surgeries, but it was statistically insignificant. This is the data we have submitted is 2014. So after that period, once we have crossed over that learning curve, the incidences have significantly more reduced. So this is just to quote and complete, and we have nearly now 1,800, 900 surgeries which we have done, and it covers the entire spectrum. The absolute indications, what I would say is this group of patients here, and if you do a surgery, then that's the day. You won't like to do another surgery after this, or even a deformity surgery is fine, but after a surgery like this you do for a fluorosis, you don't want to do even an OPD that day. So here is the group of patients wherein it will make an immense difference, because we face a lot of patients of fluorosis and ossifying disorders wherein you have done an entire spinotomy, what we call, say, triple region stenosis, significantly ossifying, fluorosis there, wherein we are able to finish off the job in, say, 2-3 hours, a triple region surgery, which we were not able to do, say, 6, 7, 8 hours with even a 2 team there. So that's the cases where you need an absolutely must for Mesonic, and as talked, for all other dorsal pathologies, for all cases of OPLLs and things, it does work wonders. This is again another indication which we have found with the technology what we have. For upper dorsal kyphosis, I have nearly stopped doing any deformity corrections, because these group of patients don't come to me for deformity, but they per se come for a worsening neurology in a month or few months time. So I have started doing only gibbectomies for this group of patients, and wherein you used to do a circumferential decompression by a bilateral approach initially, but now with this Mesonic with the 3D navigation and OARM what I have, I can do it more precise, and we can more plan it, we can sculpt, and we can exactly identify. This is the reference frame which is there, and with the reference frame and the probe, we are able to actually locate where we want to remove, what we want to remove. And this is a T incision on one side which we did with a one rib removed here. You can actually flatten the approach with the Mesonic, and this is the 3D, this is the navigated frame which is for the third party navigation, and you can cut through the osteotome there. And this is something which is to be looked on. This on the right side image, you are using this osteotome or say Mesonic just adjacent to the cord and cutting across through the body. So this is the image. This you cannot do with any of the other instruments, and I have never been able to do it. At least with burr, you can even imagine. Yes, you can use a protected hooded burr to do a bit of the job, but not really. So this is what I was talking about. For internal gibbectomy, you remove a part of the bone from inside, keeping a good shell and enough bone of the vertebral body remaining there. So with this trough created, you create this slab with cutting of this vertical cut. This is the most important cut which can be done only with this Mesonic. And once that is cut, you can just push this bone into the gap created, and you can get away with an internal gibbectomy easy. And all the bone that is preserved is again used as a bed, because the more you remove, you are not left with a lot of bone bed. That's why you need more number of screws. So you started using say 4 screws for single level fixation, and in these cases you are able to get away. And this is already published, but this is with other technological advances, say OARM, navigation, IONM, everything is there. More additional indications which you can think about is, say, Shetty sir would like to maybe using it definitely, because he uses the spinous process splitting decompression. So here it would be working excellently. You can use for routine surgeries like any other case for high volume centers. For transforaminal endoscopies, we have been struggling since years to remove the bone, which we remove by, say, burr. But in these cases, if we have some tool which is so small to reach near the lateral recess, this would be the thing which would make remarkable successful stenosis surgery for transforaminal surgery. And already there are some probes, but they are all in the process of further evolution. And exactly what the difference it makes can be understood by the orthopedic surgeons who will be doing traditional plaster cutting. The difference it made with a plaster cutter which was motorized, that's exactly the difference which you get by using a Mesonic in any surgery. Just for the sake of comparison, I would just show this video. This video is actually showing two burrs. One is a conventional burr. We have three burrs with us, and this is the asculate burr which is there. We started together, both-sided fenestration to be done. This is the burr of the Mesonic. This needs continuous irrigation there, and it is doing its work. And this is using a self-irrigated burr. This is not a cutting tip what I am showing. And after it has been finished, still you have a lot of things to be done there, and it is already there and removed the ligamentum flavum. It will not detach or remove the ligamentum flavum. I'm not talking about the cutting burr tip. I'm not talking of the osteotome. So like Anna or Shetty was talking about that, he uses the last cut very carefully with the osteotome. You can use this burr tip, because with this burr tip, you are not even endangering that just tip off into the canal. So this can be used when you are thinking of the decompressive part whenever you need, though we are more aggressive to remove it en bloc. These are the publications which you already cited. We have 3-4 publications on this already. I just went into to look into it, why it is not being used into the routine neurosurgical centers and other centers. I could quote back as 40s or 50s when already this system was there in existence, and the maxillofacial surgeons, the dental surgeons use it more profusely, and they are using it significantly with all the mentioned advantages what we were talking about. And few of the literature, because this is cosmetic surgery, so they even end up comparing the post-operative edemas to the face to define the outcome. So in these group of patients of comparative outcomes of conventional surgeries and using the other cutting burrs, when they are able to compare the pre-operative, the post-operative baseline, the 1 week after surgery, they are able to make significant difference when Mesonic is used. So we don't have any studies as of now to define the edema of the musculature, what we cut through to reach to the spine. Neither we are able to define, say, the edema difference of the cord pre-operatively and post-operatively, because we have a stenosed cord and we are not able to identify the extent of that edema, and it combines with the myelomalacia. But for the surgeries of other branches, it significantly matters in the outcome what they are comparing. And this is the osteotomy, this is Leiford's osteotomy, we'll just skip it. So is it all good? Say we are talking about something which can increase the rashness of an orthopedic surgeon, because we are always blamed as being surgeon and super surgeons. We all have passed our hostel life, and everybody would spot that this is the orthopedic guy is coming, he is hopeless. And the reason has been the rashness, the aggressiveness probably which was there. And this is again a tool which can increase your rashness, and it can label you again in some way in the wrong way. So you should be cautious as well, and you have to use it with a feather touch, as Dr. Hegde told. And just to compare, like ultrasonic bone scalpel is what we use and what probably everybody is using. There have been comparisons with other system also, like what is with a sonic, the other models which is there, striker models, the sonar, the Zurich. So what they say is that there's some amount of heat production in Mesonic is probably more, but it doesn't make a clinical difference as to what we have noticed clinically. This is another thing which we have noticed. We have already published this. We have a report of significant number of cases of pneumocephalus at our institute for a varied group of surgeries. And in this, say this is the post-operative MRI of the patient already operated by a laminectomy. And 2 days down, the patient starts complaining, and then you have got your MRI done and you are seeing the pneumocephalus there. So we have started scratching our brain for the pneumocephalus also, that is there the bubbles generated by the saw increasing any propensity towards pneumocephalus, but it is not happening with all cases. Looking to the number of cases what we have, and it is not the reason, but we have started scratching to find any reasons. And hand safety, as your hand is saved by not using conventional instruments, but is it really saving? Because these are pneumatic instruments. Whatever you are using, the pneumatic instruments are bound to create vibrations, and they create problems in your hand, neuropathies, carpal tunnel syndrome, as Dr. Hegde also said he has bilateral carpal tunnel syndrome. I would also say the number of cases which I am doing, I feel when the duration of surgery increases, you feel some lethargy in your hands. And now what has happened in the last 1 year is that I have changed the size of my gloves by half, and I have just climbed, which didn't happen so many years. So there is something with the volume of the cases which you are doing, which is still not reported there. You may end up having small things by repeated say for simpler surgeries. If you are using it and you are using it for right in and out, then you may get those type of problems as well. This was again, I tried to find out any other problems because of the ultrasound, and there have been good amount of publications on the atmospheric ultrasonic vibrations or waves which are passing, because there are many instruments which are emitting these ultrasonic waves, and that leads to a lot of concentration problems, annoyance. Even there have been reports of, say, complaints of vomiting, say nausea sensations, lethargy. These are all reported. This all is there, but this is not related to Mesonic. This is just, I try to find out what is there in the atmosphere for ultrasound generators in different field, and there I've been able to find this. Even the Wall Street Journal has quoted, can ultrasonic noise make you sick? So this is talked about thing. So to just sum up the advantages and the disadvantage, or the pros and cons, tool for cutting, it is precise, definitely it gives you speed, and it reduces the blood loss directly and indirectly with easy usage with cottonoid. And bone grafts is the thing which you can retrieve, and osseointegration, because if you are doing a laminoplasty and placing it back, because the gap created is too low, there are high chances that the osseointegration can also occur better. So that is another thing. The learning curve is definitely lesser, because for us to learn that finer burr based used, that took more time to learn than this. So this is definitely on the shorter learning curve. Dural and neural safety is there, with an X factor of, say, dural tear for specific indications when we are using, say, for all adhesions and calcifications of dura. So there you have to be safe. There is a definite role for diseases like fluorosis and ossifying disorders, and osteotomy, and in child, whenever you're doing an osteotomy, and in child, especially with what Bhau told, you need to actually save blood. And high volume centers, you can definitely speed up things. Edema, infection, pain, as Bhau told about, that the pain decreases significantly. We have observed that. And indirectly, you may be reducing the infections and the edema, because you are reducing the time, the retraction time, the handling time. Anesthesia complication itself, you are reducing. The length of the hospital stay is reducing, and the cost to the patient probably indirectly may be reduced. And coming to the disadvantages, if you want to, yes, this needs a feedback to be developed to make it more safer, and you prevent that tip of what Shetty was talking about. And adhesions, ossifications in revisions, you have to be careful. Planning of osteotomies, because once you have cut, you cannot do anything. So you need to plan where exactly you want to place it, because with a burr, you are just progressively moving. Here you are just cut off, and you can create mistakes. So you should be very much clear on that. Handpiece ergonomics is not as good as that of the burrs which we have evolved, because burrs are more finer. And one thing to be just mentioned, the burrs we use like a pen, this we use like a trumpet. So this is a different way of using. So ergonomics actually coming into our way is not there, but definitely it will improve with time. It can be rash if you are aggressive, and typical nature of a surgeon and orthopedic surgeon, it can land you in problem. Be safe. Feather touch, Dr. Hegde already mentioned it. Cost of MBBS, it doesn't make any big difference when you are comparing with a burr itself. So it doesn't cause much of a cost rise. Yes, professional hazard, we may be sitting on one, but be safe in spine surgery, and UBS does make a very big difference, and it is safe. Thank you.
Thank you, Ajay. Let me, if you can stop the share screen.
Yeah, just a minute.
Yeah, sure.
Done.
Yeah. Let me conclude few things, particularly related to the arousal generation. That is what I have looked into. And how do we really circumvent that? That's what I have few things to share with you. And then after that, we will have the discussion. What is arousal? Well, it's a day-to-day we use, particularly when you look at a lot of things, which we use for the spray that is in the household, even the fly, even the mosquito, they all have the arousal. But it can turn out to be quite dangerous in the operation theater because this arousal generated with this cautery and the tools which we use, they can have the organisms, and this high-speed high-speed bursts can really make a cloud in the operation theater. The household use of these aerosols, they usually have the formaldehyde and xylene, and they are harmful if you stay around them for a long time. What are the tools that seen in the spine surgery? They are electrocautery, power drill, power burr, and even the suction that can also cause this. In our day-to-day activity, considering to this COVID, I think we should be considering intubation and extubation that generates the arousal, and that is why room cleaning is given a lot more importance after the surgery, before the second case is taken for the surgery. And handling of the linen, like you should not be really, you should just put the linen without stretching them and handle them with care, so that whatever aerosol, whatever the organism they are there, do not really spread everywhere. Couple of articles, they say that it is not just related to the spine surgery or the orthopedic surgery, but any surgery that uses the cautery, and they have the potential exposure of the potential they can generate the aerosol. The measurement of the aerosol, I think the particles which are generated, they are 0.5 millimicron or even larger size, 1 millimicron. So that is something just to share with you. The particle could be really as tiny as 0.5 millimicron. High-speed cutters has been shown to create an aerosol cloud in the whole surgical room, and it is found in many mobile equipments. So this COVID has probably taught us this, that the disinfection of the room and the mobile equipment is really necessary after the high-speed use, which we have not been doing practically after the surgery, and the second case is taken over. So very important for all of us to learn about this. Now, what is best for the aerosol? How do we really, sort of protect ourselves from the aerosol generated by the high-speed tools? And the first thing that comes to anyone's mind would be N95 mask, and second is N100 filter, which we have been using and which we have used in our cases. This is something which I would like to share. The coronavirus is 0.125 micron. So the N95 mask is 0.3. So that is again for 8 hours. So this N100 filter, which we have used with this full mask or even the half mask, helps us in really fighting. And this is the N100 filter. So I did corpectomy day before yesterday rather, and we use this for 3 hours. And this N100 filter is something which is the ultimate for this aerosol protection. And it was quite comfortable when I used it. So something just to share with you, what is required is something like 6800 mask that really helps us. Now, what I will have is few questions with all the faculty. So I'm going to have you all live in the webinar, and we will have few questions discussed. And there are a couple of questions that has come into the question box. Yeah, my question to all the four faculty, since we have learned this tool does the best job, Sajjan, does the best job, and probably we'll have the hang of it. Suppose in the middle of surgery, we found that this is not working. How would you tackle, Sajjan?
That would be a nice situation. That's why you should always have two of these. And I've been asking my hospital to buy a second one. I don't like getting caught in these kind of situations. I don't like suddenly changing from what I have planned to doing something else. It disturbs me.
Yeah.
So I like things going in a smooth way. But to your question, we would have to revert back to our old instruments, osteotomes, the osteotome, the keratins. But I wouldn't like to be in that situation.
Yeah, thank you. What about Ajoy? What would you do?
Fortunately, we have two sets of Masonic burrs, and therefore we never had an issue where I need to change the plan because of the not acting of the Masonic burr. That's one thing.
Yeah.
But having said that, I still use a lot of burr. Therefore, I'm not very uncomfortable using the burr. But as Ajay mentioned, if he's doing an internal sculpting, then I think it will be a difficult scenario.
Yeah.
You can't have a substitute for that. It cannot be matched by a burr by any means. You can do it, but it technically takes you off.
Yeah, sure. Babuk?
So we have just one set of ultrasonic bone scalpel, and we are planning to buy the other one, as the previous speakers have said. It is essential to have two sets. The problem, which we encounter most commonly is the breakage of the tip. What happens, if you're using these tips again and again for more than 2 cases or 3 cases, then these tips, they break, especially the burr, because it is very hollow and it is, it's very fragile. So after say 1 or 2 cases, then it breaks. And in those cases, we just change the working tip.
Yeah. Ajay, if it breaks in the middle, you know that we have 2 burr, but at the same time, we had 1 burr to begin with. We have one console to begin with. If you can unmute yourself,
as the home thing should not be talked outside, but it would be Bharat sir who would stop me from using the burr frequently, and I'm damn fan of the thing. So we have two machines, we have 4 handsets, and frequently we have got few of them serviced and damaged as well. We have a hospital which I go say weekly once on Wednesday for doing practice there, and that is far away. In that hospital also, even for that one day, I have procured 1 Masonic because I'm just used to it now. So you got addicted to it. I can't just do without it now.
Yeah,
I agree with Ajay. The same thing for me. When the table is set now, there will be a burr and there will be Masonic. I cannot, irrespective of whether I'm doing a decompression or anything like that, you're just used to it because it helps you to make your surgery faster. Number one. The most important thing of using a Masonic is that you are decompressing from outside in, and you can remove the bone using a small probe so that your dural injury or a neurological worsening, especially in a OLF or situation like that, is significantly lesser. In our analysis, we find that the incidence of neurological deficit is significantly lesser in OLF patients with Masonic when compared to our time when we used to do it before Masonic.
yeah, sure. My next question is, what are the cases where you would refrain, you would not use this bone scalpel? Question to Sergeant, please. I think for all of us, the same question. What are the cases where we do not use the bone scalpel?
Frankly, I cannot think of one, Bharat. I, in fact, see more and more applications rather than less.
Yeah.
Yes. I really can't think of something where I would not use a bone scalpel and use something else instead of.
Yeah, I means when I started propagating this particular technique and, started showing the cases from C2 to L2 laminectomy in just one go, people started talking about, you are doing the indirect decompression, this and that. I try to justify, but, there are things, which you can't really put it forward when people not large, not many are using it. Ajay, is there any case where you would not do?
No, definitely
You
not.
won't
I
use
agree
this?
with Sajan on that aspect. And I would say the only instrument which you can use very comfortably near the dura is semisonic.
Yeah.
Is an ultrasonic cutter. Like now you have done a decompression. For example, you have to remove the bone which is you think is slightly left behind. I am very confident of using a Masonic very near the dura, and I cannot use an osteotome so confidently, cannot use a burr at all, and using an upcutter is probably causing more damage than that.
You see, typically these bone spurs
Yeah.
are sitting in front of the nerve root.
Yeah.
You can do a gentle retraction and go with those with spurs. In the past we would, having no other go, we would use the regular burrs with horrendous issues. This is very, very useful in that.
Yeah, sure. The undercutting is something which is a beautiful tool as well. When you have certain situations where the bone which will protect the nervous tissue as well. Babuk, any case that you would not use this?
So like the previous speaker said, we have used this in so many cases, maybe hundreds and this thing. So for us, the applications are expanding. But the one who is just starting and who is not to use this thing. So there are certain cases in which I will advise them not to use them, like in revision cases, the cases where the dura is adherent. So first they should familiarize themselves with the feel, with the tactile feedback. And once they are confident, then only they should venture into these cases. Another indication is, where you can see a calcified vessel. And if you're planning a 3-column osteotomy and that calcified vessel is very near to the, to the anterior border of the vertebra, in those cases, you should be very careful that you may not just go into this thing and you can puncture the calcified vessel.
Yeah, great. Ajay?
There is conceptually a little bit of things which is different once you are starting to handle the dural tears by the Masonic. And what you get the dural tears here, if at all it is to be there, it is usually a linear one which you can repair also. But avulsions are the things which can happen once you are through a calcified dura. And here conceptually, I would like to say off mic because it will be contradicted by most of the people. I've started doing many of the cases planned durectomies, wherein it is extensively calcified, wherein you know that it is adhered, you try to separate out the first go, and once you know that your handling is going to cause problem, so you put a nick, you excise the dura and the whole of the thing instead of manipulating and creating more injuries. See, conceptually and traditionally, what has been trained and what everybody does is that create a dural tear. If at all is there, you repair, you reinforce, you use more gels, glues, everything. I mean, that is not the way probably I learned or we got trained, and it becomes difficult for these group of patients. So even with extensive durectomies in dorsal level, it has not created any problem except for few days of delayed discharge which we have had. So this is also there. So even in say for lumbar, it may create problem because lumbar, it is rootlets which may just come out like a spaghetti. So you have to be more careful and you should avoid actually. But in dorsal, in practice, I've done this, which I would say it is off order and it needs actual stratification and publishing before I can say that that's a method.
Yeah. Question again to all. We have come across two major complications. One complication is the multi-level OLF, and we have not been able to separate the dura. And that is where I am sure that comment of decompression or lifting the laminectomy without really indirect, I would say, that is something that can cause the dural tear. And second complication, which Dr. Ajay has shown, is the pneumocranium. So how frequently you come across both these complications? One is damaging the dura, lifting the dura along with the lamina, and the pneumosyphilis. Over to question to Sajan, please.
So if you're doing like in a myelopathy and you're doing it from the front and you're doing an indirect decompression, you're actually avoiding going right down, and you invariably have issues, dural injury, of dural tears and all that, which in the cervical spine, you find it very difficult to suture or to close. So this indirect form of decompression, which I think Ajoy showed, or he showed, where you burr out for about a little bit of the two vertebrae, which you then raise up and indirectly pull up create the space in the spinal canal, so that you're not going inside at all. You're just creating an indirect decompression. So that way you avoid. Otherwise, in severe OPLL, if you try to remove everything, you end up with severe problems.
Yeah, I'm talking about the OLF, ligament of flavum, ossification of ligament of flavum.
Oh, you mean in the thoracic spine?
Yeah, in the thoracic spine, yes.
Well, we do it with our neurosurgery colleagues, and we do it with a high-powered microscope, but invariably there are tears there, invariably. When I mean, you have to expect dural tears, which are difficult to suture, which you need to patch up.
Sure. And pneumocephalus?
That we haven't seen.
Okay.
We have.
Ajay? Sure, thank you. Ajay?
Regarding the OLF, the pneumocephalus we had seen earlier in our practice. We have seen the similar like you, 2 or 3 cases. Actually, the patient doesn't have it on the day 1. He says on the 2nd or 3rd day that he hears a whoosh sound which goes from the spine to the head, and he starts getting disoriented. And this has been attributed in the literature to the suction drain that is kept.
Drain, yes.
Yeah, that has been attributed in the literature, that there is a leak when they are cleaning or emptying the drain, where the air can leak into the spinal canal and into the CSF. But usually you give hyperoxygen, it settles down. Regarding the dural tear incidents, what I have found in my experience is that once I started thinning the lamina and then cutting it, I found that I can separate a plane between the dura. Sometimes the dura comes up, but the arachnoid remains intact, because the piece which I am removing is not a thick piece. When you got a thick piece as you are removing, there is usually dura peels off. But does it cause a consequence? Usually no. And actually, I mean, sometimes you find that dural tear patients may do better than the patient who didn't have a dural tear. I don't know whether it improves.
No, same observation which we have. In the fact, we are relieved when we see that dura is completely off.
Yes.
And you can see that, you know, and then the most important thing is CSF doesn't leak when there are major dural tears as well.
I agree with you and Ajay in the fact that my primary aim is to decompress. If the dural tear happens during that process, let it happen. I'm not going to stop because I think that the dural tear is happening. I don't like the aspect of floating, because I believe in OLF it cannot float.
No.
And that's my understanding, that the bone which is indenting onto the cord will remain like that, and it doesn't allow the cord to float.
Yeah. Babu?
Yeah, same here. I haven't seen any pneumocephalus. I haven't seen in my practice. And dural tears, they happen, and they are usually of no problem whenever we are managing these cases.
Yeah. Any Ajay, would you like to give any thought about, you know, because he has told about the suction. Dr. Ajoy told about the suction, which we have all the time worried about.
It is a typical observation what he mentioned, and it is the suction drain only which is the reason for.
Yeah. We were thinking of, Ajoy, we were thinking that, you know, there is a lot of air, which also along with the fluid going into the canal, and that may be one of the reasons, because when you look at the dorsal spine, the pneumocephalus occurs at the D12 level. If we have operated, it goes right up to the cranium. We don't know, you know,
have to understand, but I think it happens usually after the 2nd or 3rd day. It doesn't happen immediately.
Yeah.
And one more thing regarding Sargent's demonstration of doing a costectomy. I mean, you should be done like how Sargent does. The pleura has to be completely separated.
Yeah.
If not, even if you are using this one, there's a lot of fluid, and it can collect inside the pleural cavity if there has been a small rent. But Sargent has nicely demonstrated that he separates the pleura. Absolutely. There is a significant gap between the rib and the pleura.
Between the two, yeah. Sure.
Otherwise, the fluid can go inside. The pressure is more. It can present as a post-operative hemothorax.
Sure, sure. If you have to give a message to those who are participating, I would say that this is the miracle tool, and I am sure, you know, everyone probably is going to use more and more. And we have been seeing a lot more indications coming as well. And we use this tool for the laminectomy when we do the intradural tumors as well. So we put it back. We lift the whole lamina and then we put it back as well afterwards, and we suture it. And we have found zero CSF leak when we do this procedure. And probably we have preserved the anatomy. So, we are able to, if suppose somebody there is recurrent tumor, then we can go back again. That is one which we have been practicing since last few years. And the another thing which I practice in the corpectomy, if it is bleeding quite a lot, then again I redo the cut, corpectomy cut, meaning about a millimeter lateral I go, and then the bleeding stops. So on occasions these venous openings can be stopped with this heat generated as well. So I do the recut of the corpectomy cut. In conclusion, I think the bone is cut in such a way so that the blood loss is less. The Ajoy has shown beautifully about the use of the burr and the Mizonex bone scalpel. I think that is something which is unique. Dr. Sarjan has demonstrated very well on the bone model, and as well as his cases, the grant cases and the grant correction. And really, I feel honored, and I'm sure audience is going to feel honored as well that this is something your first webinar, and probably we'll have you in the second webinar as well, whenever we do it in next week or maybe sometime near. Another thing, I think it was narrated that paintbrush use, type of the use we should be using this bone scalpel, and not to give pressure. That was mentioned all the time, and that is something which anybody who is started using new should not use the pressure on it. Do not remain on the same spot more than few seconds, otherwise it will burn the tissue. It may not lead to the damage, but I'm sure it will lead to the blackening of the dural sac. And I think probably we can really convert this tool, which is a trusted tool from osteotome and the charism, to the trustworthy tool, I would say. And this bone scalpel can become the trustworthy tool and the miracle tool as well. There is a question from Dr. Maria. The literature suggests that there is increased temperature at the cortex. So would it cause osteonecrosis? Yes, certainly it is going to cause osteonecrosis. Anyone wants to take that question, Ajoy?
It causes osteonecrosis, but your area of fusion where you are using is not at the site where you are using the osteotome. Yeah. Therefore, you are using your area of fusion. For example, if you are doing an interbody, this is an access where you are removing the facet joint. It might have certain issues, like for example, when you are doing in a scoliosis, when you are doing a ponte, your fusion is between the lamina and the lamina. Is not between the cut surfaces of the bone. Therefore, it should not have any major impact. But you have to remember, just because you are using Misonic, you cannot compromise on your preparation of your bed, which is an essential part of your fusion surgery.
Yeah, sure. I think question can be answered by Babu. Guru Raj has asked, can you use this for PSO? Is there a problem?
No, we didn't have any problem, and such a normal tool for PSO, like for any osteotomy, you have to just be careful because the exiting nerve root has to be taken care of, and you just go in the single back and forth movement, then there is no problem.
Yeah. The most important thing about, anything that if you use the high speed burr, there is always worry that it will catch the tissue. Here, that is not a problem. So that is why, one can say that this is a safer tool. There is a question from Dr. Sarfaraz for Sarjan. He typed this question when you were giving the talk. Dear sir, is there any cardio space compromise due to change in the current anatomy position? Probably he was talking about the scoliosis case which you had.
No, I mean, we haven't done a study or anything, but I don't think it interferes with the fusion. I don't think so. It causes very local, I don't know if you can term it osteonecrosis. It temporarily causes the bleeding, the normal bone surface which bleeds, it prevents that bleeding. But I don't think it kills the bone. I don't think so.
Yeah, sure. Thanks to Cure Surgical for initiating these talks as well. and immediate names came, and I'm sure, you know, everyone has given excellent input and few tips as well, starting from tactile feeling, not to pressure the bone, and the damage is inadvertent on certain cases as well. Thank you everybody for being part of this webinar. Thank you all the faculty for sharing their experience, and thank you Cure Surgical for arranging and organizing this as well.